بسم الله الرحمن الرحيم. Breast fibrocystic changes imaging. Fibrocystic changes are extremely common, occurring in 90% of women at some point in their lives. Most fibrocystic changes tend to occur with younger and premenopausal women. Clinical course: fibrocystic change represents a clinical problem in approximately 30% of patients. Predominantly affected are women with menstrual abnormalities, nulliparous women, patients with a history of spontaneous abortion, non-users of oral contraceptive, women with early menarche and late menopause. Early fibrocystic manifestations may occur between age of 20 and 25 years, but most patients in their mid-30 and 40 years, but can occur at any age. Clinically, three phases of fibrocystic change can be recognized in clinical course. Phase 1, moderate stromal fibrosis, beginning hardness of breast tissue and premenstrual breast tenderness. Phase 2, progressive fibrosis leading to increased hardening and tenderness, cyst formation, moderate medularity. Phase 3, pronounced fibrosis and tenderness, macrocyst formation. Clinical features: the common clinical presentation consists of palpable, dense, irregular, lumpy, pumpy consistency, lumps in the breast, usually multifactor and bilateral, associated with breast pain or tenderness that fluctuates with menstrual cycle and becomes progressively worse until menopause. Symptoms of fibrocystic change: breast pain, cyclic mastalgia, lumps in one or both breasts, breast swelling, breast tenderness, breast thickening, unusual nipple discharge. Three hallmarks of fibrocystic change include cystic change plus metaplasia, fibrosis, adenosis. These three components of fibrocystic change: cystic change plus fibrosis and adenosis. Aberrations of normal development and involution. ANDI. ANDI is wide spectrum of disease or physiological change and the classification of prime breast disorders, disorder of development, disorder of cyclic change, disorders of involution. Fibrocystic change in 1, disorders of ANDI, disorders of involution include fibrocystic breast disease, fibrocystic change, chronic mastitis, mammary dysplasia. All these name synonymous for fibrocystic breast disease. Include a variety of changes in the glandular and stromal tissue in response to the level of estrogen and progesterone, and often presents with cyclical breast pain, mastalgia. Fibrocystic changes include cysts, fibrosis, sclerosing adenosis, ductal ectasia with periductal mastitis, ductal ectasia, periductal mastitis complex. ANDI, aberrations of normal development and involution. There is 5 pathological features are present in ANDI: cyst formation, adenosis, increase in glandular tissue, fibrosis, epitheliosis, papillomatosis. Epitheliosis means proliferation of epithelium lining the ducts and the acini. Papillomatosis means formation of papillomas due to extensive epithelial hyperplasia. This is 5 basic pathological features of ANDI. Fibrocystic change is one disorder of ANDI, which includes cyst formation, adenosis, and fibrosis. Fibrocystic change stages. First stage, intense proliferation of the stroma. Second stage, adenosis. Adenosis means multiple small breast nodules vary from 2 to 10 mm in diameter. Third stage is cystic phase, vary from microscopic to 5 cm in diameter. Vocal fibrocystic changes usually correspond to cystic degeneration of breast parenchyma associated or not with fibrosis, adenosis, and ductal or lobular hyperplasia. Benign, non-cancerous condition. This is focal fibrocystic changes. There are many terms used to describe fibrocystic change, like fibrocystic breast disease, not used now, diffuse cystic mastopathy, vocal sclerosis of the breast, chronic cystic mastitis. Fibrocystic change may be vocal or diffuse. What's the difference between fibrocystic change and cancer? Fibrocystic breast disease affects the females mostly in the reproductive age group. Fibrocystic change is a benign condition. Fibrocystic change influenced by hormonal changes which occur during menstrual cycle. Fibrocystic change, lumps of fibrocystic disease are fibrous in nature. Texture is smooth and mobile. Lump not spread to surrounding tissue, never go beyond the breast tissue. Fibrocystic disease is a painful condition, can affect one or both breasts. Do not spread or grow do not spread this fibrocystic change. Fibrocystic change grows very slowly and regresses with decline of hormonal level. Fibrocystic change will have swelling and tenderness of the breast that will keep varying with the hormonal fluctuation in the body. Breast cancer is a condition where there is uncontrolled growth of cells of the breast and the lump are formed in the breast tissue. Breast cancer leads to lumps which are not smooth and spread to the adjacent tissues rapidly. Breast cancer most often a bilious condition which infiltrates the deeper tissue as well as distant lymph nodes. Fibrocystic change pathomorphology includes three components: fibrosis, cyst formation, and adenosis. Fibrocystic change either vocal or diffuse. Fibrocystic change in the breast tissue, there is three major pattern morphological change as we talked before, including fibrosis, formation of cysts, proliferation of glandular tissue, adenosis. Fibrocystic breast has a dense, irregular, bumpy consistency. What's mean of adenosis? Adenosis is a abortive breast disorder characterized by an increase in the number and size of glandular tissues, acini and ductules, within usually the expanded breast lobules. Cysts, second component of fibrocystic change. Cysts either simple, round or oval shaped, well defined with a uniform outer margin, demonstrating no asymmetry or unusual thickness of the wall, imperceptible wall. This simple cyst may be complicated cyst, may be complex cyst. Complex cyst with solid component, thick wall, intracystic mass, internal septation. Number of cysts may be single or multiple. Distribution of cysts, multiple, either clustered or discrete. Size of cysts from microcyst, medium size, large cyst up to 5 cm. Fibrosis and fibrocystic change, either vocal or diffuse. Vocal fibrocystic change may be proliferative or non-proliferative. What's mean? Proliferative fibrocystic disorders are epithelial proliferation is one of the common breast fibrocystic disorder. Non-proliferative fibrocystic disorder are those in which problem has not been caused by new or unexpected cell growth. Fibrocystic change of the breast, either non-proliferative or proliferative. Cyst formation and fibrosis is non-proliferative fibrocystic change. Proliferative without atypia or with atypia. Without atypia include epithelial duct hyperplasia, sclerosing adenosis. With atypia include atypical duct hyperplasia, atypical lobular hyperplasia. Focal fibrocystic changes classification, either non-proliferative lesion, as we took before, include cyst, papillary apocrine change, epithelial related calcification, mild epithelial hyperplasia, simple ductal ectasia, non-sclerosing adenosis, periductal fibrosis. Proliferative lesion without atypia, moderate or florid ductal hyperplasia, sclerosing adenosis, radial scar, complicated duct ectasia, intraductal papillary proliferation. Proliferative lesion with atypia, atypical ductal hyperplasia, atypical lobular hyperplasia, intraductal papillary proliferation with atypia. Imaging and finding of vocal fibrocystic changes of the breast. In mammography, opacity, asymmetrical density, distortion, microcalcification. On ultrasound and elastography, include cysts, either complicated, complex, present in cluster or secret, mastopatic nodule, mastopatic plaque, distortion, duct ectasia isolated or associated to plaques or cyst cluster. Risk factor in ultrasound study by Doppler signal, intrinsic Doppler signal. Ultrasound elastography risk factor, stiff lesion, score 3, 4, 5. MRI changes or presentation of vocal fibrocystic change, either cyst, mass-like, asymmetrical glandular parenchyma with or without distortion. Risk factor in MRI enhancement characteristics, intense asymmetrical gadolinium uptake, enhancement curve change. Vocal fibrocystic change and BIRAD. Fibrocystic change may be categorized into BIRAD 3 or 4 according to imaging finding. Is fibrocystic breast disease a pre-malignant state? Benign breast disease has generally been reported to be associated with a relative risk of from 1.5 to 3 for breast cancer. Few studies have failed to find any association between fibrocystic breast disease and breast cancer. Breast lump classification in general. 30% of breast lump no disease related to fibroglandular component. 40% is fibrocystic change breast lump. So most common pathological breast lump focal fibrocystic change. Cancer represent 10%, fibroadenoma 7%, miscellaneous benign 13%. Fibrocystic change report. We report fibrocystic change as in mammography as dense fibroglandular architecture of the both breast or one breast with micronodular pattern, multiple well-defined variable-sized rounded densities are seen scattered in all quadrants of both breasts. Complementary sonography referred these densities are seen-walled simple cysts. Breast fibrocystic changes ultrasound study. Ultrasound role in fibrocystic change. Ultrasound finding in early stage. Ultrasound appearance may be normal. Even so, lumps may be palpable in clinical examination. There may be vocal areas of thickening of the parenchyma with or without patchy increase in echogenicity. Ultrasonographic findings include cyst formation. Cyst formation calcification may occasionally be seen in cyst, milk of calcium. Cyst may be simple, rounded, or oval shape, well-defined sonolucent lesion with a uniform outer margin, demonstrating no asymmetry or unusual thickness of the wall. Imperceptible wall. The central part of the mass show no echoes. There is posterior wall enhancement. This characters ultrasound character of simple cyst. Cyst formation may be complicated cyst with internal echoes, may be clustered microcyst cluster plus duct ectasia, complex and solid complex cystic formation, complex solid and cystic masses, thick wall, intracystic mass, internal septation and solid component. Cyst may be ruptured or inflamed cysts. Cyst formation, first ultrasonographic finding. Second, duct ectasia. Duct ectasia isolated or associated to plaques or cystic cluster. Tabular and echoic structures radiating in a centripetal fashion towards the nipple in a non-lactating. May be scattered echogenic foci due to calcification present in ultrasonographic finding. So, cyst formation, duct ectasia, calcification. Fibrosis. How is present in ultrasonographic finding? Fibrosis seen as echogenic area, either vocal or vocus or diffuse. Vocal fibrocystic change may be either appear as solid mass as a result of fibrosis or thin-walled cyst. Secret masses due to fibrosis. So fibrosis present as echogenic area or mass-like, either diffuse or vocal. Ultrasonographic findings include mixture of fibrosis and cystic change may present. Heterogeneous ecotexture when mixed with residual fat. Mixed hyper and hypoechoic ovoid mass or mass-like. Can appear irregular with shadowing, often requiring biopsy. This mass. Sometimes often difficult to distinguish from malignancy, often require biopsy if present as vocal mass, which require biopsy of vocogenic tissue due to fibrosis, sometimes difficult to be differentiated from malignancy, or uniformly ill-defined vocal echogenic lesion or mass with or without posterior attenuation. So, Fibrocystic change may present as diffuse change or vocal. Vocal change, it's difficult sometimes to differentiate from malignancy and require biopsy. Vocal change may be echogenic due to fibrosis or hypo or isoechoic, mass-like, and can appear irregular with shading, which classifying as BIRAD 4. This is require biopsy. Ultrasonographic finding, methopatic nodule, methopatic reflexive Picard architecture distortion. Doppler ultrasound show intrinsic vascular signal, and this is risk factors not usually present. Intrinsic vascular signal because vocal fibrocystic change formed mainly of fibrosis. When we found intrinsic vascular signal, the risk factor classified as BIRAD 4. Elastography show what? Showed in general soft lesion, assess stiffness degree, and risk factor of score 3, 4, 5. Risk factor intrinsic Doppler signal, elastography stiff lesion, score 3, 4, 5. Now we start imaging. We see image of varieties of fibrocystic change. Keep this image in your mind. This is one of the common presentation of fibrocystic change. Lady come to complain of pain and maybe lumpy breast. What we see, only vocal areas of thickening of parenchyma with patch increase in echogenicity. Maybe this only manifestation of fibrocystic change. Cysts. Cysts may be clustered or non-clustered, secrete multiple cysts. Cysts may be vary from microcyst to large 5 cm cyst. This is multiple cyst secrete in breast parenchyma, fibrocystic change. Clusters, small cyst, multiple cyst clustered in area, different in size and shape. Secret multiple cyst. Multiple cysts not clustered, present away from each others. This is fibrocystic change. Clusters of small cysts, one of the common manifestation presentation of fibrocystic change. Cluster of a small cyst present, multiple cysts different size and shape present in groups. Fibrocystic change may be single cyst or may be multiple. The single cyst present fluid field, usually benign, seen walled, regular, smooth, circumscribed, completely cystic, simple, no solid component. Secret multiple cysts present in different area. Fibroadenoid cystic change in fibrocystic change disease, fibroadenoid cyst. Hypoechoic lobulated well-defined mass in the breast. Few anechoic spaces, cystic area are present. This is fibrocystic change in breast. We present as hypoechoic or echogenic area or mass-like lesion. Cystic change, fibroadenoid cyst in fibrocystic change disease. Cyst which is not simple. This cyst may be complicated with internal echoes or solid component complex cyst. Cyst present fibroadenoid cyst in fibrocystic change. Another fibroadenoid cyst complex and complicated. fibroadenoid cyst present in fibrocystic change by color and 3D, simple, completely cystic, thin wall, and we do gain test as we demonstrate later on to differentiate if there is solid mass or not. Left breast axillary tail fibrocystic change present as hypo to isoechoic area, irregular, lumpy, and this is maybe scored by RAD4. Fibrocystic change cyst, fibrocystic change breast seen, complex cyst, maybe complicated, hypoechoic mass composed of multiple cysts and dilated ductal segment, duct ectasia, may be isolated or associated to micro or cysts, with a vessel show stiff area within elastographic study. Heterogeneous ecotextures of microcysts, this presentation of fibrocystic change. Single cyst in fibrocystic change. Cluster of microcysts in fibrocystic change present in mammography as dense irregular area, asymmetric density, vocal. Clustered cysts appear as asymmetric density on mammogram, making malignant lesion. Clustered microcyst in fibrocystic change. Complicated cyst with shallow level internal echoes. Complex cyst, partly solid, partly cystic, dedicated fine needle aspiration biopsy, classified, categorized as by RAD4. Gain setting, gain test. This normal setting show an echoic appearance. Right side with increased gain still show an echoic appearance confirming cystic nature. This is normal gain, we show an echoic appearance of simple cyst in fibrocystic change by RAD3. When we increase gain to detect or test for presence of solid component, still an echoic appearance present confirming cystic nature. Gain setting, normal setting show an echoic appearance. Increased gain show filling of lesion suggesting solid nature. This is fibrocystic change. Heterogeneous ecotexture and echogenic areas in fibrocystic change. Heterogeneous ecotextures and multiple microcysts in fibrocystic change. Heterogeneous ecotexture, echogenic areas and microcysts in fibrocystic change. Heterogeneous ecotextures and echogenic areas due to fibrosis. Oval hypoechoic mass with multiple small cysts in fibrocystic change. Circumscribed oval complex cystic and solid mass with posterior enhancement and adjacent clustered microcysts in vocal fibrocystic change. Variant fibrocystic change, multiple small cysts isolated to this region of breast. Clustered circumscribed oval complex cystic and solid mass, posterior enhancement and adjacent clustered microcyst. Heterogeneous ecotexture and echogenic areas. Heterogeneous ecotexture and echogenic areas due to fibrosis. Multiple small cysts. Scattered echogenic foci due to calcification. typical fibrocystic change by RAD2 benign, heterogeneous ecotexture and ecogenic areas, heterogeneous ecotexture and ecogenic areas in fibrocystic change, diffusely heterogeneous ecotexture, multiple small cysts, diffuse scattered ecogenic foci due to calcification, typical fibrocystic change by RAD2 benign, heterogeneous ecotexture, ecogenic areas due to fibrosis and multiple microcysts, heterogeneous ecotextures with ecogenic areas due to fibrosis, multiple microcysts. Is typical one of the presentation of fibrocystic change. Multiple cysts seen ultrasound disappear on aspirations. This is disappear on aspiration, fibrocystic change. Present in mammography as dense breast, which can be obscured by dense fibroglandular parenchyma. This is dense breast obscure cyst which is seen in ultrasound. Fibrocystic change, complicated cyst, impure content, thinner than white, score 2 by elastography. Initially classified as by RAD3 lesion, it looked risk-free, but it wants surgery, patient request, and histological result mild epithelial hyperplasia, non-proliferative mastopathy. Fibrocystic change, ultrasound and elastography show thick wall complex cyst by RAD4A, complex cyst, internal echos, and solid component, stiff in elastography, classified as by RAD4A. Fibrocystic change, ultrasound and elastography. Ultrasound show cluster of microcysts plus duct ectasia and microcalcification. Minimal marginal signal at Doppler. Ultrasound show non-rigid lesion, score 2. This is classified at all as by RAD4A. Lesions without Doppler or radiographic risk element present are proven as non-proliferative lesion, fibrocystic change plus periductal fibrosis. Combined ultrasound and elastography show small soft nodule, score A by elastography, classified as by RAD3, stationary course and consecutive follow-up. Doppler ultrasound and real-time elastography. There is irregular hypoechoic mass thinner than white, partially ill-defined, no acoustic shadow, with intrinsic Doppler signal, risk signal, and score 4, rigid in elastography, classified, categorized as by RAD4P. This nodule has all imaging risk factor and the biopsy confirmed proliferative mastopathic lesion. Finally, it's radial scar. Ultrasound and elastography show a small hypoechoic nodule with vertical orientation, slightly irregular contour, avascular stiff on elastography, classified as by RAD4A, biopsy confirmed nodular fibrosis. Doppler ultrasound in real time show elastography and real time show distortion with acoustic shadow and slight marginal vascularity, classified as by RAD4A. Core biopsy show epithelial hyperplasia and fibrosis. Fibrotic component explain stiff aspect on elastography. This is case ultrasound, real-time elastography, Doppler, complex cyst with intrinsic pseudomass, marginal Doppler signal, soft in elastography, and also demonstrated by mammography in this area, classified as BIRAD 2. Confirmed to be benign fibrocystic change. Differential diagnosis of fibrocystic change in ultrasound. For cyst, differential diagnosis duct ectasia. For complex cyst, oil cyst, galactocele, hematoma, abscess. For cyst in cluster with or without duct ectasia, differential diagnosis ductal carcinoma in situ, ductal carcinoma in situ plus invasive ductal carcinoma, invasive lobular carcinoma. For nodules in fibrocystic change, differential diagnosis is fibroadenoma, invasive ductal carcinoma, atypical ductal hyperplasia, lobular neoplasia, ductal carcinoma in situ. For Plicard differential diagnosis, ductal carcinoma in situ, invasive lobular carcinoma. For distortion, differential diagnosis is steatonecrosis and invasive ductal carcinoma. Ductal ectasia periductal mastitis complex. Wall of the inflamed duct becomes thickened and irregular, one of differential diagnosis of fibrocystic change in ultrasound. Duct ectasia comparison with fibrocystic disease. In cystic change in fibrocystic disease, mainly lobular, affect any part of breast, no nipple discharge, no nipple retraction, no inflammatory disease except ruptured cyst, can be associated with epithelial hyperplasia, cysts surround or ovoid with thin yellow to brown content, no elastic layer in cyst walls, epithelial lining usually apocrine, mammographic calcification more amorphous, scattered, not in line of duct. But duct ectasia present as ductal disease mainly affect major duct and subalveolar duct. Nipple discharge in about 20% of this duct ectasia with clinical disease. Nipple retraction common due to periductal fibrosis, usually periductal chronic inflammation, usually no epithelial hyperplasia, present as irregularly dilated duct with thin content initially, followed by clearly comedo-type content. Other ducts obliterated partially or completely by fibrous plaque. Duct ectasia usually statistically in ductal wall elastic tissue stains, elasticity in elastic ductal wall. Apocrine metaplasia very rare in ductal ectasia. Calcification common in periductal fibrosis, producing tabular, annular, and linear shadow on mammography. Differential diagnosis of fibrocystic change, atypical ductal hyperplasia, lobular neoplasia, ductal carcinoma in situ. This is examination showing lactating woman with complex thick wall cystic lesion, well circumscribed posterior enhancement without Doppler signal and elastographic pattern. BIRAD 2, it is galactocele and not fibrocystic change. And this is case complex cystic lesion, thick wall, vascularized, internal echoes, stratified pattern in elastography. BIRAD 4A pathology proved to be hematoma, one of differential diagnosis of fibrocystic change. This is case present complex cystic lesion, stratified pattern in elastography, marginal Doppler signal, it is breast abscess. Combined, we found this case upper inner quadrant of the right breast, patient present with hemorrhagic nipple discharge. Study ultrasound shows cluster of cyst, ductal ectasia, non-specific mosaic elastography, classified as BIRAD 4B, biopsy confirmed ductal carcinoma in situ, one of differential diagnosis of fibrocystic change. This is case present, showed ultrasound show minimal change such as subtle distortion, abnormal Doppler signal risk factor within a vocal area composed of what seemed to be small complicated microcysts, internal echoes, an elastography stiff appearance score 4. The small nodular image reinforced examination opinion toward guided biopsy, classified as by RAD 4B, pathology confirmed ductal carcinoma in situ, invasive ductal carcinoma, invasive lobular carcinoma. Ultrasound Doppler show real-time elastography with soft hypoechoic mass, well circumscribed minimal Doppler signal scored by RAD 3 proved to be fibroadenoma. This is either inferior quadrant of the right breast, ductal carcinoma in situ, mesobatic-like nodule in elastography score 3, classified as by RAD 4B, biopsy confirmed ductal carcinoma in situ. Small irregular hypoechoic or isoechoic nodule stiff in elastography, score 4 and 5 in elastography, slight posterior shadowing, classified as by RAD 4C, pathology for both cases invasive ductal carcinoma. Ductal carcinoma in situ, placard-like lesion, hypervascularized, stiff score 4 elastography, classified as by RAD 4-3, core biopsy show ductal carcinoma in situ. This is another case with another placard-like lesion, intrinsic vascularizations, placard-like lesion, intrinsic vascularizations, same stiff appearance in elastography, score 4, classified, categorized by RAD 4C, core biopsy show invasive lobular carcinoma. This is case with showing architectural distortion in ultrasound, stiff lesions in elastography without vascularity in Doppler in a traumatic context, cystiatonecrosis. Breast fibrocystic changes in mammography. Mammographic finding dense breast parenchyma as seen by mammography plus breast cyst best seen by breast ultrasound. Mammographic finding. Early fibrocystic change shows small areas of increased density on the mammographic film. These are irregular, scattered with varying degrees of density. As these progress, dark areas may occur along the whitish gray areas, and microcalcification may also become prominent. Nodular changes are reflected in the mammography by darker peaks amid dense white areas appearing as bloodshot breast. Fibrocystic change being dense pattern approximately 20% of women between age 39-49 and 5% between age 50 and 59 and 0.5% of age 60 or above. Mammographic finding. Mammographic finding in breast fibrocystic change. Mammographic finding of first component fibrosis, second component adenosis, third component cyst formation. Mammographic finding of fibrosis and adenosis, mainly asymmetrical density and distortion. The dense structure of fibrocystic breasts makes it difficult to optimally appreciate the existence and or morphologic feature of opacities corresponding to cysts, vocal fibrosis, or nodular adenosis. So opacities seen in mammography may correspond maybe to cyst or to vocal fibrosis or nodular adenosis. Finding can be vocal, regional, or diffuse. asymmetrical densities أو opacities presentation, architectural distortion like radial scar sclerosing adenosis. Sometimes this finding occult in mammography due to high breast density. Mammographic finding of cystic change seen as opacity or asymmetric density or distortion. Fibrocystic change of the cystic type of varying size, which may or may not be visible by mammography, appears as an individual round or ovoid lesion of low density with low secret smooth margins. A changing pattern of bilateral, partially circumscribed, partially obscured masses due to cysts developing and regressing. So, carefully examine each mass to assure margins are no worse than partially obscured. At least 75% margin visualized and circumscribed. Any suspicious, dominant, or secret symptomatic mass dedicated ultrasound examination. Other masses other than cystic change, like fibrosis, may present in mammography as focal or global asymmetry, oval or irregular mass. Can be differentiated from malignancy, may require biopsy. If we cannot differentiate this is masses from malignancy on mammography, this is indicated require biopsy. Like in nodular adenosis, typically oval, mostly circumscribed. Sometimes cannot be differentiated from malignancy. Mammographic finding in fibrocystic change is another one, microcalcification. Calcification take various shapes and presentation. Punctate amorphous calcification most common. Involutional type, fine punctate calcification, evenly distributed within one or more lobes against a fatty background. In such cases, percutaneous biopsy usually required to exclude ductal carcinoma in situ. May be diffuse, scattered bilateral calcification, mostly punctate, some coarse heterogeneous amorphous calcification, occasionally random loose groupings expected. Punctate amorphous calcification. Another morphology or shape of calcification, teacup-like calcification in horizontal beam. Another one, rounded smudged calcium on craniocaudal projection, depicting the classic milk of calcium, which is pathognomonic for fibrocystic change. Or microcalcification seen in adenosis, apocrine metaplasia, ductal hyperplasia are among mammography findings associated with fibrocystic disease. This calcification may be single, multiple, small flecks located intraductal or periductal stroma or entire lobules. Differential diagnosis, attention to microcalcification, which may correspond to ductal neoplasia. So if you cannot differentiate, you go to biopsy and tissue study. So mammographic finding of calcification may be punctate amorphous calcification, teacup-like calcification, round smudged calcification, microcalcification. Fibrocystic change present as group of calcifications, pleomorphic, punctate, different shape. Fibrocystic change in mammography, we show clustered pleomorphic calcification and stereotactic biopsy in this old woman showed fibrocystic change intraductal hyperplasia and sclerosing adenosis. This mammogram lateral mammography show layering of some of this regional calcification compatible with milk of calcium. It's pathognomonic for fibrocystic change. Others do not layer calcium, promoting stereotactic biopsy proved to be fibrocystic change with sclerosing adenosis. Variant fibrocystic change, this is mammography MLO, show left asymmetry, the background of heterogeneous dense parenchyma. This old woman. Other fibrocystic change mammography case, MLO, show dense parenchyma with left breast lump seen asymmetric density. This is craniocaudal mammography. This is 45 woman show dense parenchyma with diffuse bilateral scattered punctate calcification and coarse heterogeneous calcification. Patient has reduction mammoplasty. Pathology proved diffuse fibrocystic change in reduction specimen. Close up of this right craniocaudal show diffuse scattered punctate and coarse heterogeneous calcification. Cluster of microcysts in fibrocystic change present as area of asymmetric density in the mammography, circumscribed, partially ill-defined. This is clustered microcyst in fibrocystic change in ultrasound, present as asymmetric density in mammogram, mimicking malignant lesion, partially circumscribed. Bilateral mammography showed dense parenchyma with bilateral regional punctate and coarse heterogeneous calcification, few calcium layer, milk of calcium, which is pathognomonic for fibrocystic change. This is MLO and CC, show right breast a cluster of pleomorphic suspicious microcalcification in a linear and branching distribution, categorized as BIRAD 4C, proved by histopathology as benign non-proliferative massopathy and typical ductal hyperplasia. This is detailed MLO of left breast, show cluster of pleomorphic calcification, showed excision biopsy categorized by RAD4B result ductal carcinoma in situ and invasive ductal carcinoma. One of differential diagnosis of fibrocystic change microcalcification. This is bilateral CC, show asymmetric density, and this is classified, categorized by RAD4A. Biopsy show mild epithelial hyperplasia and fibrosis. This is diffuse dense breast global asymmetric density of case of fibrocystic change. Areas of vocal asymmetric density, multivocal area in the left breast, one of presentation of fibrocystic change. Left global asymmetry seen in CC and MLO corresponding to palpable mass of fibrocystic change. CC mammography show subtle cluster of amorphous calcification in case of fibrocystic change. Milk of calcium, which is pathognomonic for fibrocystic change. Cyst and ductal carcinoma. This is one of differential diagnosis of fibrocystic change present as area of vocal asymmetry. Fibrocystic case reporting like dense fibroglandular architecture of the both breast with microglandular pattern, multiple well-defined, variable-sized rounded densities are seen scattered in all quadrants of both breasts. Ultrasound reveals that densities seen walled simple cysts. Breast fibrocystic changes in MRI. MR finding include cyst, mass-like asymmetrical glandular parenchyma with or without distortion. MR finding in T1 cyst typically of signal intensity, isointensity parenchyma, variable signal when hemorrhagic or pernicious, may show fluid debris level. In T2 fat smear, fat suppression, scattered cyst present as variable signal content, proteinaceous relatively hypo-intense, fluid debris level may be seen. Occasionally clustered microcysts observed through resolution can be limiting. Occasionally clustered microcysts observed through resolution can be limiting. T2 with fat suppression, fat saturation, scattered cyst present as a variable signal content. T1 with contrast plus fat suppression, inflamed cyst present as a smooth rim enhancement of cyst wall 2 mm or less in thickness, scattered foci of enhancement in MR less than or equal 5 mm, diffuse bilateral. Fibrosis can present as diffuse regional or vocal enhancement. Fibrosis may show suspicious kinetics, irregular mass over requiring biopsy. MR finding more diffuse type of non-mass lesion showing benign enhancement, kinetic pattern with medium wash in early phase, vocal mass type lesion with enhancement, kinetic usually show a rapid up slope mimicking a breast cancer. Non-mass patchy enhancement pattern is found. Non-mass in MRI kinetic enhancement curve may suggest it either as benign or malignant feature, rendering it to be non-specific. Demonstrating medium early phase kinetic enhancement, fibrocystic disease of the breast highly suggested. Cyst clusters, non-mass-like regional enhancement displaying 3 types, all type of curve. Risk factor in MRI, intense asymmetrical gadolinium enhancement curve. T2 MR show multiple small cysts, high risk in screen female, fibrocystic change. T1 with contrast show diffuse scattered foci of enhancement, typical fibrocystic change by RAT2 classification. Triangular area of enhancement, persistent enhancement, T1 with contrast. A triangular segment of multiple tiny cysts in T2 corresponding to area of enhancement, fibrocystic change. Axial MIB shows scattered bilateral foci of enhancement, not secret suspicious area. Fibrocystic change, mammographic MLO and ultrasound elastography show architectural distortion, acoustic shadowing corresponding to regional enhancement area with wash-out kinetic MRI curve. Patient present with palpable lump, score by RAT4, core biopsy impress invasive ductal carcinoma. This is patient present with breast fibrocystic change on ECR mammography. MR shows several regional enhancing lesion displaying curve, plateau curve. Ultrasound show nodular and placard-like vocal lesion with microcalcification, hypovascularized, soft in elastography, stationary in delayed follow-up, scored by RAT3 fibrocystic disease. This is family history: woman with cancer, bulbar placard, light breast, ultrasound show only cluster, cyst cluster without risk factor. MR show cyst cluster in the right breast, post contrast cyst cluster. In TT1 with contrast, vocal 8 mm enhancing lesion in the right breast. Enhancement kinetic curve show rapid upslope followed by plateau, classified as by RAT3, stationary in course in follow up by MRI. Post contrast subtracted T1 showed vocal enhancing non-mass like lesion with wash out type 3 curve, and ultrasound and elastography show suspicious area, intrinsic vascularity, stiff score force elastography, score by RAD4C, core biopsy show florid ductal hyperplasia, proliferative massopathy. This family history of breast cancer, female, by RAD4 in this breast, post contrast T1 showed vocal centimetric enhancing landmass like lesion plus distortion, wash out curve, and wash out. Examination during appropriate period of menstrual cycle. Ultrasound not show any lesion. MR appearance normalized. 6 months follow up. After 6 months follow up, it means show it normal. Same patient. Perform examination during 10th menstrual cycle. This examination done during 18th day of cycle, showing like enhancing mass, but it's not true. This is all the patient prior surgery to right breast. Pathology show nodular sclerosing adenosis. Control MR after 1 year show mass like enhancing lesion plus distortion associated to scar with slight wash out kinetic. By RAD4B steatonecrosis. This is different MR images features of fibrocystic change, light patchy enhancement, diffuse heterogeneous enhancement, small mass-like lesion with wash-out kinetic mimicking malignancy, small mass with benign enhancement kinetic. This is woman vocal fibrocystic change, T1 and color kinetic, speculated appearance of lesion with rise suspicious of malignancy, will define strongly enhancing lesion, kinetic curve show rapid upslope suspicious for malignancy. It is difficult to differentiate with this technique normal of fibrocystic tissue, glandular tissue in T1 and T2 weight sequence without contrast. It is difficult to differentiate normal or fibrocystic tissue glandular parenchyma in T1 and T2 without contrast. Heterogeneity observed after administration of contrast due to many cases, in many cases due to areas of serial proliferation, alternating with areas of regressive change as fibrosis and cyst. Important asymmetric regional enhancement in the upper left quadrant, contrast enhanced T1 weighted fat saturated with internal heterogeneous enhancement. Color could show foci of maximal slope of enhancement increase after contrast injection. Wash out kinetic type 3 curve. Fibrocystic change. Differential diagnosis fibrocystic change in MRI. False vocal enhancement with distortion due to an appropriate menstrual cycle period during examination. Regional enhancement with wash-out invasive ductal carcinoma. Mass-like enhancement with distortion plus wash-out in cystitis. Fibrosis, invasive ductal carcinoma, posteriorly seen, one of differential diagnosis of fibrocystic change in MRI. Breast fibroadenosis imaging. Breast fibroadenosis composed of two parts, fibrosis and adenosis. Adenosis, what is mean? Adenosis is a proliferative breast disorder characterized by an increase in the number and the size of glandular tissues, acini and ductules, usually within the expanded breast lobules. Fibroadenosis within pathologic spectrum of fibrocystic breast disease. Fibroadenosis within pathologic spectrum of fibrocystic breast disease. Fibroadenosis. Fibroadenosis equal fibrosis plus adenosis. Fibroadenosis within pathologic spectrum of fibrocystic breast disease. Fibroadenosis is the distortion and overgrowth of one or more components of the breast. The components of the breast are ducts, lobules, and fibrous tissue in between. Fibrous tissue, fibro, and the epithelial layer adenosis of the ductal become hyperplastic. Therefore, we have the name fibroadenosis. This occurs as an abnormal physiological response to the circulating hormones. Fibroadenosis within pathologic spectrum of fibrocystic breast disease without cyst formation. Fibroadenosis in one of the ANDI. ANDI, it's aberrations of normal development and involution. Physiologic dynamic structure change through the life in the breast. Aberration in normal cyclical hormonal effect. Fibroadenosis and breast cancer. Fibroadenosis do not mean there is increased risk of developing breast cancer. There is no evidence to suggest this at all. A person with fibroadenosis may develop breast cancer, but this is unrelated. Fibroadenosis clinically, classic presentation is painful and tender lump. The pain is usually cyclical with menstruation, cyclical mastalgia with nodularity. Pain often the presenting complaint and no lumps are seen. The lumpiness of the breast may be diffuse or nodular. Types of fibroadenosis. Simple fibroadenosis, sclerosing adenosis, hardening combination of stromal sclerosis and adenosis. Nodular subtypes formed solid mass like nodular adenosis, adenosis tumor, nodular sclerosing adenosis, differentiated from adenomas, back-to-back gland without intervening stroma. This nodular adenosis. Another type, microglandular adenosis, MGA, extremely rare variant of adenosis, characterized by proliferation of ductules lacking myoepithelial cell layer but retaining basement membrane, background collagenous stroma. Other minor subtypes of breast adenosis include apocrine adenosis, adenomyoepithelial adenosis, blunt duct adenosis. Pathomorphology, fibrosis and adenosis. Fibroadenosis plus cystic change equal fibrocystic changes. Fibroadenosis include fibrosis and adenosis without cystic change. Mammographic case reporting in fibroadenosis, like dense fibroglandular architecture of the breast with micronodular pattern, multiple well-defined small rounded opacities are seen scattered in all quadrants of both breasts. Dense fibroglandular architecture of both breasts with no speculated lesion, no vocal lesion. This example of how to report case of fibroadenosis in mammography. Mammographic finding, fibroadenosis, calcium most common finding. More common in sclerosing adenosis than simple adenosis. Amorphous calcium may be round and punctated calcification more than pleomorphic. Mammographic finding in fibroadenosis, increased brain density, either generalized or diffuse asymmetric density, calcification, more common in sclerosing adenosis than simple adenosis, microcalcification, clustered or scattered, and amorphous may be punctated, less common oval circumscribed mass with or without calcification. May be incidental finding in biopsy, microcalcification. Imaging finding of calcification vary among pathological subtypes. Sclerosing adenosis, calcification found in 47%. Most common morphology is amorphous calcification in sclerosing adenosis. Another third mammographic finding after increased brain density calcification is size or masses, usually small, average 12 to 25 millimeter, often admixed with other element of fibrocystic change with or without prophytic change, usually duct hyperplasia, fibrosis, cystic change, apocrine metaplasia. Sclerosing adenosis especially can be admixed with atypical lesion. So three main findings in mammographic fibroadenosis: increased brain density, calcification, masses. Ultrasonographic finding of fibroadenosis: simple fibroadenosis, prominent glandular parenchyma, prominent ductules, coarse heterogeneous breast, abnormal thickening area, dense fibroglandular parenchyma, no vocal lesion or duct dilatation. Sonopalpation may show mild probe tenderness. Fibrosis seen as hyperechoic area, hyperechoic lines. No appreciable vascular enhancement seen. Normal breast tissue, as we see in MB mode and 3D. Normal breast tissue with 3D ultrasound. Fibroadenosis ultrasound. Prominent glandular parenchyma, prominent ductules, coarse heterogeneous breast, abnormal thickening area, dense fibroglandular parenchyma, no vocal lesion, no ductal dilatation. Fibrosis may be seen as hyperechoic area, hyperechoic lines. Fibrosis seen as ovoid hyperechoic area in fibroadenosis. Fibroadenosis ultrasound, prominent heterogeneous breast, prominent fibroglandular parenchyma, abnormal area of thickening of dense fibroglandular parenchyma, no vocal lesion or ductal dilatation. Fibrosis seen as hyperechoic area, hyperechoic lines. This is another case Also, ultrasound fibroadenosis show prominent dense fibroglandular parenchyma, prominent ductule, coarse heterogeneous prominent dense parenchyma, abnormal thickening area, fibrosis seen either as hyperechoic areas or hyperechoic lines. This is fibroadenosis by 2D, 3D ultrasound. Also seen prominent, dense, coarse, heterogeneous breast parenchyma, fibrosis seen as heterogeneous areas or hyperechoic areas or hyperechoic lines. Fibroadenosis in ultrasound, in this case, coarse, heterogeneous, dense fibroglandular breast parenchyma, prominent ductules, abnormal thickening, fibrosis seen as hyperechoic areas, hyperechoic lines. This is another case with the same criteria: coarse, heterogeneous, prominent fibroglandular parenchyma, prominent ductules may be seen, fibrosis seen as hyperechoic area, hyperechoic lines. This is area seen with areas of fibrosis, hyperechoic area, hyperechoic line, coarse, heterogeneous, prominent fibroglandular parenchyma, no mass, no vocal lesion, no ductal ectasia. Ultrasound right breast detect as hard mass, irregular border, very strong posterior attenuation without axillary lymph node. Result of biopsy: fibroadenosis with calcification. This is breast show coarse heterogeneous mass-like lesion, irregular border with high attenuation, posterior shadows, acoustic shadows. It is fibroadenosis case. Fibroadenosis, coarse, heterogeneous, prominent fibroglandular parenchyma, no mass, no ductal dilatations, fibrosis seen as hyperechoic area, hyperechoic lines. Another ultrasound case of fibroadenosis with prominent hyperechoic area and hyperechoic lines or of fibrosis. This is real-time elastography and Doppler ultrasound showing architectural distortion, hypoechoic irregular ill-defined area with acoustic shadowing, intrinsic vascularity, ultrasound elastography stiffness score 4, classified as BI-RAD 4B. Imaging feature suggests proliferative lesion, biopsy prove sclerosing adenosis and radial scar. Fibroadenosis present coarse, heterogeneous, dense fibroglandular parenchyma, no mass, no ductal dilatation, abnormal thickening, fibrosis seen as hyperechoic area, hyperechoic lines. This is another case, ultrasound of fibroadenosis, coarse, heterogeneous, dense fibroglandular parenchyma, normal thickening area, no mass, no ductal dilatation, fibrosis seen as hyperechoic area, hyperechoic lines. This is ultrasound and ultrasound elastography show hypoechoic irregular inhomogeneous placard, palpable, lumpy, soft in elastography, score 2 BI-RAD 4A, proved to be non-sclerosing adenosis. Mammography in simple adenosis. This is CC mammography show regional amorphous calcification as well as few incidental coarse benign dystrophic calcification. Lateral mammography shows layering of milk of calcium, and the biopsy show fibrocystic change with sclerosing adenosis microcalcification. Fibroadenosis in mammography, dense fibroglandular architecture of the breast with micronodular pattern, multiple well-defined small round densities are seen, no vocal lesion. Dense fibroglandular parenchyma architecture of the breast in mammography in fibroadenosis, no vocal lesion. Fibroadenosis in mammography case asymmetric dense fibroglandular architecture with no vocal lesion. This is mammography detect calcification mass in the right and left breast with dense fibroglandular architecture reported as BIRAT4 breast tumor proved by biopsy as fibroadenosis with calcification. Fibroadenosis, this is case in mammography, right breast CC, show area of dense fibroglandular architecture, no vocal lesion, microcalcification, but proved by biopsy as lobular carcinoma. Mammography in fibroadenosis, simple fibroadenosis, show generalized dense left breast, no vocal lesion or ductal dilatation seen. This is CC mammography show ill-defined mass with vocal asymmetry and calcification. Spot mammography abnormality in the left breast show partial thinning, spot compression, case of simple adenosis. Sclerosing adenosis. This is another type of fibroadenosis we talked before about finding in simple adenosis. Sclerosing adenosis meaning adenosis equal stromal sclerosis. Sclerosing adenosis proliferation of acini in the lobule usually appear to have invaded the surrounding breast stroma. Proliferation of acini in the lobules which may appear to have invaded the surrounding breast stroma can simulate carcinoma both grossly and histologically. Sclerosing adenosis finding in mammography may be seen as normal mammography or vocal architectural distortion, circumscribed masses, calcifications with clustered or scattered punctate amorphous and pleomorphic. Most frequently pattern is pleomorphic. Amorphous calcification with or without rounded punctate calcification, commonly pleomorphic. Speculated mass, asymmetric vocal density combined with macrocalcification. So sclerosing adenosis in mammography may be normal, may be show vocal distortion, calcification, asymmetric density, or mass, speculated mass, which must be differentiated from carcinoma by biopsy. Ultrasound in sclerosing adenosis. Either vocal acoustic shadowing without mass configuration or mass like area. This mass seen as over circumscribed hypoechoic mass, nodular adenosis, microlobulated mass, indistinctly marginated speculated mass. Ultrasound also show echogenic calcifications, may increase vascularity seen in ultrasound Doppler study. Show ultrasound finding in sclerosing adenosis vocal acoustic shadowing without mass or mass echogenic area of calcification, increased vascularity may be seen. MRI in sclerosing adenosis usually undifferentiated from background breast parenchyma. Nodular sclerosing adenosis seen as circumscribed, indistinct or partially obscured oval or round solid mass without calcification, less commonly irregular mass with indistinct margins, may be speculated in combination with RSL. Appearance may be undifferentiated from malignancy. Sclerosing adenosis in mammography may be present as mass. This mammogram show palpable lump corresponding to a circumscribed oval mass containing single coarse calcification. Ultrasound of the same case show hypoechoic circumscribed mass with posterior enhancement and the calcification seen in mammography evident in ultrasound. Sclerosing adenosis mass. Sclerosing adenosis CC mammography show partially circumscribed mass, low density mass containing punctate calcification. Ultrasound finding sclerosing adenosis. First case heterogeneously echogenic areas. In second case, mass lesion. Third case, mass lesions with calcification. Last case as vocal acoustic shadowing. Ultrasonography of mass lesion with acoustic shadowing. This is old woman, asymptomatic, no palpable abnormality in physical examination. Mammography negative because extremely dense breast tissue. Ultrasound show irregularity, contoured mass with acoustic shadowing. Final diagnosis sclerosing adenosis. As this is difficult to be differentiated from carcinoma, dedicated biopsy and tissue study. This is ultrasonographic finding in sclerosing adenosis and may be seen malignant sign in these cases. Firstly, hypoechoic mass with an irregular shape and distinct angled margin. This is reported as BI-RAD 4C, confirming by biopsy as complex sclerosing adenosis. Next case, heterogeneously dense echogenic area with rich blood supply, scored as BI-RAD 4B, confirming as sclerosing adenosis with ductal epithelial hyperplasia. Next case, pear-like mass with diffusely punctate calcification, scored by BI-RAD 4B, diagnosed by biopsy as sclerosing adenosis with calcium deposition. Last mass seen as irregular mass in ultrasound, angled margin, clustered microcalcification, scored by BI-RAD 4B, confirming as sclerosing adenosis with atypical ductal hyperplasia and calcium deposition. This is old 43-year-old woman with breast pain, do ultrasonography, irregularly shaped microlobulated hypoechoic nodule seen in the left breast, no vascularity in the nodule assessed as BI-RAD 4A, low suspicion, and biopsy proved to be sclerosing adenosis. These two Doppler ultrasound and elastography show placard nodule with imaging risk features, intrinsic Doppler signal, score 4 tissue elastography stiff lesion, categorized by BI-RAD 4B, biopsy showing sclerosing adenosis, profitable massopathy. This is old woman with mastalgia, 42, left MLO mammography shows architectural distortion. Ultrasound shows speculated mass with acoustic shadowing. Case of sclerosing adenosis. Mass lesion in this woman present with thickening in the left upper quadrant. Case of sclerosing adenosis. This is oval opacity, partially ill-defined, with suspicious microcalcification located, and this is scored by BI-RAD 4C, pathologic results sclerosing adenosis. This is post-lumpectomy for ductal carcinoma in situ, recent change in the upper outer breast in magnification, grouped faint punctate and amorphous calcification, directly lateral and superior to the lumpectomy, suspicious to recurrent duct carcinoma in situ. This is old woman with vocal fibrocystic change of the right breast. Sonography of the breast show 8 mm hypoechoic lesion and post-enhanced show enhanced lesion in the same location. Biopsy done show fibrocystic change with vocal sclerosing adenosis. MRI of this study letter reveals that previous enhanced lesion is removed. Only 20 enhancement is the same lesion. Next type of fibroadenosis is blunt duct adenosis. Blunt duct adenosis detected by mammography and ultrasound as clusters of punctate microcalcification, masses with well-circumscribed margins, non-circumscribed margin, vocal acoustic shadowing. This is woman presented with mastalgia. Mammography was negative with dense breast composition. Vocal acoustic shading without mass seen in ultrasound. This is blunt duct adenosis, one type of fibroadenosis. Microglandular adenosis, another type. MGA is uncommon rare type of fibroadenosis, present as masses, non-circumscribed margins, or speculated mass, hyperechoic mass with a distinct margin and microlobulated mass, asymmetry, architectural distortion. This is old woman with left mastectomy, spot compression showing speculated mass of microglandular adenosis. Differential diagnosis of fibroadenosis, most common differential diagnosis is dense breast. Differential diagnosis, another one, invasive ductal carcinoma, present with speculation, distortion, favor malignancy, ductal carcinoma in situ, present with pleomorphic calcification, linear or segmental calcification, favor ductal carcinoma in situ, atypical ductal or lobular hyperplasia, can have amorphous calcification, tubular carcinoma mimic at histopathology, presence of actin, myoepithelial cell layer P63 in adenosis and sclerosing adenosis lost on tubular carcinoma. This ductal carcinoma in situ, microcalcification, pleomorphic, linear, dissegmental. Fibroadenoma with punctate calcification or popcorn calcification, character of fibroadenoma. Atypical ductal hyperplasia, one of differential diagnosis of fibroadenosis. Character of discharge per nipple, if milky prolactinoma, of green mammary duct ectasia, black or blood-stained duct papilloma or carcinoma, clear mucoid, may be breast cancer.